Hey everybody, welcome back to the ECG channel. My name is Reed, and today we're going to go over atrial tachycardia, or another way you can call it is ectopic atrial tachycardia. So you might see it a few different ways. And so this is different from sinus tachycardia in that the sinus node isn't causing the tachycardia, somewhere else in the atria is. And so what do I mean by that? Well, let's start off by just reviewing typical conduction in our cardiac system here. Usually our SA node fires off, depolarizes the atria, which is when we get our P wave. Our AV node captures that signal, delays it by 120 to 200 milliseconds, sends it down to the ventricles, and we get depolarization of the ventricles, which creates our QRS, and we get our T wave for our repolarization. And so that's just a quick review over kind of what is typically happening. And we know that sinus tachycardia can occur when the sinus node is beating above 120 milliseconds, but atrial tachycardia, or ectopic atrial tachycardia, as its name implies, this is an ectopic focus that is driving the tachycardia. And what do I mean by that? So what I mean is there's a focus, and we will say that this focus is located, in this case, right here in the left atria. And this focus decides to get a little bit angry and fire. And when that fires, we get a wave of depolarization through our atria, which causes our P wave. And then our AV node, which in this case is a bystander, it's going to receive the signal from the atria, and in the normal fashion, it's going to conduct that signal down our His-Purkinje system, and we're going to get ventricular depolarization to cause a normal QRS. So what is occurring in ectopic atrial tachycardia? Well, it's tachycardia. So for one, the rate needs to be greater than 100 beats per minute. And two, there needs to be P waves that are, hint, hint, not sinus. So usually this is a very regular tachycardia, and is being driven by these P waves that are not sinus. And what do I mean by that? Well, we know that our sinus P waves, typically, when they arise from our sinus node right here and they fire, the sinus node is in the upper right-hand corner of our atria. And when it fires down to the left. So a sinus P wave goes down and to the left, which means it's going to be positive in lead 1 and positive in AVF. So in lead 1, in AVF, which measures if something is going down or to the left, we're going to have a positive P wave. In an ectopic atrial rhythm, where this rhythm is coming from somewhere else in the atria, maybe it's down here, when that wave of depolarization spreads, notice it's not going to be spreading down to the left. So you're going to see P wave morphology that can be all different types. It can be coming from the bottom left like that. It can be coming from the bottom right and be spreading up and to the left. So really what we need to determine is we need to find ectopy. We need to find specifically atrial ectopy that is driving this rhythm. The rest of the rhythm, the QRS, should be conducting in the normal fashion. And so let's take a look at a rhythm that is a good classic example of ectopic atrial tachycardia. And so what you'll notice, if I look down here in the rhythm strip in lead 2, get a better color here in lead 2, you see we've got this narrow complex QRS that is occurring, and it's happening right now at a rate of roughly 100 beats per minute. Sometimes a little less, sometimes a little more. And so what we can now do is we can say, okay, we've got this tachycardia. Let me figure out, one, we know that this is a narrow complex rhythm. So we know it's likely coming from the AV node and propagating down into the ventricles through the His-Purkinje system. And so now we figure out, well, what is my atria doing? And if I look up in lead 1, I have got downgoing P waves. My P waves are negative. So I have negative P's in lead 1. And that tells me that my P waves are going from right to left. And I've got negative P's in AVF, which tells me that it's going from bottom to top. So if I add those two together, that tells me that my atria is depolarizing up and to the right. So that is my P wave axis. And that is very much ectopic, right? And so a good way you can see is all in my inferior leads, 2, 3, and AVF, we should have an upright P wave, but notice all the P's are downgoing. My PR interval is normal. It is in between 120 to 200 milliseconds, which tells me that my AV node is working appropriately. And we have a nice narrow QRS. And if you notice, our QRS is, in this case, depolarizing in the typical fashion. And so, if we march through, we see these ectopic P's occurring before our QRS in a regular fashion at around 100 beats per minute. And so this is an ectopic atrial tachycardia. And so sometimes you might see this as just atrial tachycardia. And the interesting thing about ectopic atrial tachycardia is if we go back to our initial diagram, the rates of this atrial ectopic focus can vary. And so sometimes it can actually be beating so fast. If I have an ectopic focus here, sometimes if its rate is too fast, if it's got a fast atrial rate, if this is firing off, sometimes the AV node will capture a beat and send it down to the ventricles. And sometimes when the next ectopic beat occurs, if that atria or if that AV node is still refractory, it might block that beat. So sometimes we can actually have an ectopic atrial tachycardia. If the atrial rate is extremely fast, our AV node might have something that we might see as 2-to-1 conduction. And that 2 represents 2 P waves to 1 QRS. And that's because this ectopic focus is beating so fast that every time it depolarizes the atria, when it reaches the AV node is going to be refractory every other beat because it's still taking time to repolarize. And so let's take another example of an ectopic atrial tachycardia with a 2-to-1 block. And so you look at this and you say, okay, I've got a narrow complex QRS. It's quite regular. And whenever I look at what the atria is doing, I'm like, okay, I do see some atrial activity. But I notice that the atrial activity is downgoing in my inferior leads. And it is somewhat isoelectric in the lateral leads. So this is really telling me that my P wave axis is going up. P wave axis is up. And that would not happen in a sinus beat. That would happen if it was ectopic atrial activity. But something interesting that I notice is that my T waves, which are typically supposed to be broad and slopey, in this case, if you look at the T waves, I have my P here, I have my QRS, and then the next thing should be the T, but if you notice, I've got another sharp, jaggedy P wave that occurs really kind of in the middle of that T wave. And if you look closely down here in lead 2 rhythm strip, you can see I've got P's that are marching through. And so what's happening is I've got this P conducts to this QRS, this P blocks. This P conducts to the QRS, this P blocks. And so I know that they're blocking, and I know that they're P's because of the morphology is this negative morphology, and it's superimposing itself on the T wave, if you can see that. And so this is a good example where you see P that conducts, P that blocks, P that conducts, P that blocks, P that conducts, P that blocks. So this is an atrial tachycardia that is occurring. This is my atrial rate here. That's occurring maybe at 170 beats per minute. And in this individual, their AV node is unable to conduct every single atrial depolarization. So it's conducting every other. So this is an ectopic atrial tachycardia with 2-to-1 conduction. So I hope this helps you understand atrial tachycardias. Really, main things to look for is the morphology of our P waves. Are they going down and to the left? Make that a habit for you when you're looking for, to determine what the atria is doing. If you see that the P wave axis is abnormal in the context of the rhythm that we're looking at, what does that signify for you, right? In this case, we've got these narrow QRSs that are depolarizing in typical fashion. We're trying to figure out what's driving it, and we see an ectopic focus is driving this, and it's actually occurring so fast that it's conducting from the AV node to the ventricles only half of the time, or with 2-to-1 conduction, right? Remember, the AV node is a bystander in this case, and is only going to be able to conduct as fast as it can. So, hope this helps, and have a great day.